morning, everyone. Thank you for being here with us on a Saturday to our day 2 of our ultimate 4-part series on concepts in ECMO. And I'd like to introduce you. Well, let's. We have to do the housekeeping things first. I'm sorry. So let me talk to you about our social media platform, which is going to come up here over my left shoulder here in just a second. There it is. So we need you to please subscribe to our YouTube channel. We got a good number of people yesterday, but we need even more. And we also need you to please like us on Facebook. So please like us on Facebook and follow us on Twitter and share us some more. You cannot share us enough, please. With that said, what I'd like for you to do is, I lost my train of thought, guy. Which camera am I supposed to be doing? I go to 3? Okay, there you go. I'm trying to figure this out. I apologize. So thank you. I'm sorry about that, guys. So with that said, we're live streaming to YouTube, Facebook, and Twitter all simultaneously. So you can look from any of those platforms, all of it in HD. The chat feature on YouTube looks like this, so you can see it here on this side. You have to have a Gmail account, and you can ask your questions, and I monitor it from right here on my computer. We also have a call-in number. When you see the phone lines are open, here is the number that you can call, and you call that number. Please turn the volume on your computer down and talk to us directly on the phone. The phone is right here. I answer it. We hear you over the speakers. You hear us through the various microphones, but you have to have your volume down or it's very distracting with a lot of feedback. And you can always go back and play it later to see how you sounded. But we'd like for you to call us and be live on the air. It really makes for the conversation, for the program to be more lively. So don't be shy, call in or chat if you feel more comfortable with that. Also, Facebook is monitored by somebody else, and if you have a good question on Facebook, ask it, they'll hand it to me, and then we will ask it. Please tell us who you are, what your discipline is, and where you practice. That would be very helpful. So let me introduce our esteemed faculty. Immediately to my right is Kimberlee Spurlin. Kimberlee is a nurse who graduated with her associates in 2001 and later with her BSN in 2010 from UT Arlington. She is currently in a master's program to work on her nurse practitioner in acute care at also UT Arlington, right? Mm-hmm. She has been an ICU nurse since 2002 in various Houston hospitals, currently at Memorial Hermann, the Woodlands Hospital since 2010, and that is a satellite hospital of Memorial Hermann TMC. And it has become really, the Woodlands, that area has become the medical center of the North, really, at the end of the day. In fact, you're a level 2 trauma center.
Correct.
The only reason, level 2 versus level 1 is only whether you're a teaching facility. So everything that can be done in a level 1 hospital, short of doing teaching, not that they can't, they just don't, that's that distinction. So it's quite an interesting place. We get a lot of tough cases there, very high acuity, and a lot of trauma as well. She has roughly 10 years, or nearly 10 years, I should say, of both ECMO and CRRT experience, and she has been the ECMO trainer at Memorial Hermann, the Woodlands, for as long as I can remember, and does an exquisite job of that. Next to her right, of course, John Ingram. You met him yesterday. I gave him a more formal introduction. He was actually one of our faculty speakers. He's going to be on our panel today. But of course, just to remind you, John graduated from Texas Heart Institute. It was UT or St. Luke's THI?
Both at the same time. University of Texas was
both UT and THI.
Program at the time.
Very good. Okay, and he's been working for nearly over 30 years as a clinical perfusionist with 15 years of experience as a chief perfusionist. He's currently in Orlando, Florida. He's well published. He does a lot of lecturing, and if you were with us last night, if not, I highly recommend you go back and listen to his talks on essentially the underappreciated kidney, and how delivery of oxygen and phenylephrine affect acute kidney injury, or potentially are a contributor, a significant contributor to AKI. And we're going to talk a lot about that with Kimberlee's talk, and also tie that in with Dr. Balan immediately to John's right. And Dr. Prakash Balan is at UT TMC. He has done his medical training and his residency in cardiology from the University of Texas Health Science Center in San Antonio, as well as Rush University Medical Center in Chicago. His clinical focus is complex, high-risk percutaneous coronary interventions, acute myocardial infarction care, and catheter-based therapies for valvular heart disease. I know Dr. Balan from covering a lot of his TAVR cases, and I have one. Actually, I want to show it to people. I've never seen a gradient, an aortic valve gradient of 120 millimeters of mercury before in my life. And I've been doing this for 40 years. I am the oldest person in here. I look like this because I started out sniffing halothane when I was very young, and I first started as a perfusionist, and that had a petrification process on me. So I look younger than I really am. Nevertheless, and he did, after the TAVR, the gradient was 5 or less. It was incredible. Also he does a lot of hemodynamic support, very interested in ECMO, which is a topic that this is really about, but ECMO doesn't live in a vacuum. ECMO is there for a purpose. That purpose is to keep everything alive. So it all ties together, and by the time we're finished with the 4-part series, you'll see that. His research interests include outcomes in transthoracic aortic valve replacement, as well as acute MI and cardiac arrest systems of care. He also takes an active interest in clinical education. Obviously, you're here, which we appreciate so much. You guys play such a huge role in advancing the level of care for all of our patients by being willing to be here on a Saturday morning. So my hat's off to you, and we appreciate you very, very much. All of you, as a matter of fact, everybody, and you too, out in the web audience that are watching this program, even those here in the studio audience sitting over there. And he is the co-director of the CCU. So with that said, I think that was not too bad of an introduction. I think I did pretty good. Mine's a lot shorter than this. You know, some of these guys are really smart, and it's hard to compete. But you know, we need to, as mid-levels, and I consider the three of us sitting to Dr. Balan's left basically all to be mid-levels. Whether you're an ICU nurse, especially with this level of experience and that level of acuity, not just any ICU, but also John as a perfusionist, me as a perfusionist, CRNAs, PAs, nurse practitioners. We really have to depend on, we need to advance ourselves to achieve the level up versus everyone else trying to achieve the level down when it comes to these kinds of presentations and programs. And I think we've done, both as professions, an exquisite job of that. I think we've done an excellent job, and I'm very pleased. I wish I was younger and I was just starting in medicine, because as crazy as it is, I think that just the way things are changing in technology and the advancements in medicine that I see, I hate to think that I'm going to, unfortunately, be in a little jar on somebody's desk somewhere, hopefully, or in a display case, when so many neat things are just on the horizon. So, Kimberlee, would you like to start your presentation?
Absolutely.
Great. Okay.
So this is a very, very, very condensed version, just basics.
No, you go ahead.
Okay, sorry. Of a much longer presentation for ICU nurses doing CRRT at the bedside, and obviously coordinating with our perfusionists when we coordinate together when we hook into an ECMO circuit. Can you flip to the next slide?
Oh, yes, here.
Okay, which one? CRRT is any extracorporeal blood purification therapy intended to substitute for impaired renal function over an extended period of time and applied for and aimed at being applied for 24 hours a day. Obviously, we don't make urine every other day in 4 to 6 hour increments. So for our profoundly hemodynamically unstable patients, this works phenomenal to achieve our goals of therapy. So our treatment goals: maintain fluid, electrolyte, acid-base balance, and eliminate metabolic waste, and obviously mimic the native kidney. Prevent further damage to kidney tissue. So I tell people when I think of utilizing CRRT, it's the balloon pump or the Impella for our kidneys. So you have acute injury, we want you to rest and recover and hopefully leave with the same function you came with. Promote healing and renal recovery, safe anticoagulation with minimal clotting, and safe fluid removal for the hemodynamically unstable, critically ill patient. And it also allows us other supportive measures such as nutritional support. Indications for CRRT: renal replacement, obviously hyperkalemia, acidemia, pulmonary edema, regulation of acid, base, and electrolyte imbalances, and then renal support, fluid removal in CHF, cytokine manipulation in sepsis, and treatment of respiratory acidosis in ARDS, fluid management in multi-system organ failure. So the biggest application with starting it in 2010 was obviously when we had the H1N1 patients that went into ARDS, multi-system organ failure. This worked phenomenal for those patients. You get them on early, start your therapy early, and you could have them off within 3 to 5 days with full renal recovery. There's CRRT, there's different modes of therapy. So first one is SCUF, slow continuous ultrafiltration. Primary goal is volume removal, your heart failure patients. In my facility where I work, we rarely use this form of therapy. The most utilized one is CVVH, although when I teach people to set it up, we use the Prisma. I have everybody set it up in HDF, so as we move through different therapy modes, we're not losing filters in between. So CVVH is continuous veno-venous hemofiltration. Primary goal is to achieve small, medium, and large molecule clearance through convective and to remove patient fluid. CVVHD, so there's a D in it, so continuous veno-venous hemodialysis. Primary goal is to achieve small molecule clearance through diffusive and remove patient fluid. And then HDF combines CVVH and CVVHD, continuous veno-venous hemodiafiltration. Primary goal is to achieve small, medium, and large molecule clearance through convection and diffusion and remove patient fluid. Wanted to put a picture in there of the Hemofilter. Personally, at my facility, we use the M150 and the HF1400. Again, we use the PrismaFlex. There's Next Stage. There's, I think, Bebron still out there on the market.
No, they're gone.
They're gone.
They have
Okay.
a new machine, but it's in Europe, and Baxter has sued them, and so they're trying to launch it here in the United States, but they're being blocked.
Okay. So initially, when I first started, used Bebron, and then I went from that to Prisma. So I can't speak for any experience on the Next Stage because the majority of what I've used is the PrismaFlex. So very user-friendly machine. They actually probably involved nursing and some input in design, and that's the one that we utilize at my facility. So diffusion, movement of solutes from an area of higher concentration to an area of lower concentration. Dialysis uses a semi-permeable membrane for selected diffusion. So I always tell people to think of making a cup of hot tea to remember it. Major factors affecting diffusion, concentration gradient of blood and dialysis, dialysate flow rate, molecular size, and a few slides here will show you the Dalton's. Diffusion only clears small molecules and permeability of the membrane. Convection, or solute drag, the forced movement of fluid with dissolved solutes. So I tell people with this, think of a coffee press if you've ever used one of those. Major factors affecting convection: membrane permeability, molecular size again, degradation of filter membrane. This will decrease performance and life of filter, and replacement fluid flow rate. This is a slide just reviewing molecular weights. So where this comes in with your small, middle, and large. So as a bedside nurse, your raging sepsis patient with CKs off the chart, you have to do lots of finagling to maintain your filter patency because of all of those large molecules that are going to clog. So you can clog and clot. You have to figure out which your machine is doing, because Prisma will only tell you that you're clotting. So this just comes with time and experience and running the therapy and utilizing resources like this one, help you figure out how to split fluid on scales, which is why I tell everybody to set it up in HDF, so that if we need to start splitting and running some fluid pre and post to try and maintain filter life, we can do that. Ideally, you want 72 hours on a filter. Your sepsis patient, in reality, you're not going to get there. So whole treatment goal with therapy, obviously minimize downtime, keep your patient on your therapy times as long as you can. So as a bedside nurse, your goal is keeping and maintaining your filter. So CRRT access, you obviously have vascular access via a Quinton or inline via a ECMO circuit. So the biggest thing with the Prisma, with the last software update, when you initially went through setting up, it would ask you whether your access was going to be positive or negative, and you would set that in there. Obviously, when you're running through a Quinton, your access is going to be negative. Now, when you utilize and hook into an ECMO circuit, initially when you very first start your therapy, it's going to give you a warning, override, access extremely positive, because now our blood is being thrown back at our access side. So you do a manual override, you do that once, twice at the most, and then the machine knows that to adjust and now expect the access to be positive. Biggest thing with that, when you're hooked in your higher flow, we've had some finagling issues and having to adjust and put in a stopcock, because sometimes when you're flowing 5 liters, that's a little bit too much pressure coming back at your machine, so you've just got to slow it down a little bit and adjust. And so that's where we work closely with perfusion in hooking into our circuit. I personally involve my perfusionists, just like I don't expect them to go over and touch my patient and my pumps. We work as a team together when we go to hook up.
Why do you look at me?
Work very closely. So what I did was I included some pictures in here of, this was a patient that we had recently, was centrally cannulated, couldn't come off pump, profound cardiogenic shock, multi-system organ failure, and was on VA ECMO that came back, and we could immediately call nephrology. We had orders before the patient came back from the OR, and started our therapy without any delay as soon as we had her settled in, and probably had it up and running in 10 minutes. So allows for immediate access versus having to wait for a Quentin to be placed. And, you know, in patients like this, in actuality, you run out of spots for access. So this allows us to immediately start therapy. And then I just have two other pictures closer up, and I will let Joe discuss where we hook into our access and return line here.
Thank you. I think you're doing a really good job with this so far, but so yeah, I don't know if, let's see, does the mouse work? Yeah, okay. So on the CRRT, what we do is we actually have the access, and as you know, oh, what happened? We take the access from the positive side, and then we take the return and put it on the venous access side. You see it here. So here's our access to the CRRT machine, and our return from the CRRT machine is on the negative side. So there, I've explained that.
There.
Now the only other thing I could complain about is, I wish y'all would have picked those lines up away from the floor. They bother me.
They weren't touching the floor. Okay. So kind of breeze through mine pretty quick.
Oh, that's it?
Questions, comments?
Oh, okay, so that was your last slide?
That was the last slide because
Oh,
I
so
thought
you
I only
actually-
had 30 minutes.
You did very good. Okay, very good. Well, I think we can break this subject down a little bit. So getting back to the access into the CRRT machine, not only do you have to worry about not having a site for your access, but now you've got to worry about sticking a patient who is more than likely very coagulopathic. And so I think it really adds a dimension when you can do that. Now with that, some of the other CRRT dialysis machine, forget it. You're not gonna hook a dialysis machine up to ECMO. It will never tolerate those pressures. But what's your experience? You've never used the next stage, but I know they use it down in the med center at Methodist, I believe it is. But they have to use stopcocks and turn them partially in order to be able to control the pressure so that it's not so high. And so they have to do a lot of monkeying with it. I don't think that's wise. You know, I don't think that's a good idea. And of course, but there's other reasons. But you know, I mean, do you know much about the next stage machine?
Me personally, no. No.
Okay, so well, I don't want to get into that, but let's talk about the uses of CRRT. I think a lot of people view it as only for patients that need dialysis, but you had a whole host of things. Dialysis, of course, is very good for a lot of things. You know, in the chronic kidney patient, it is the go-to, and it's the right thing to use. But in the acute setting, when you have an acidemia, you have electrolyte derangements, you have multiple pressures and hemodynamic instability and gross fluid overload, or anosarchic. Talk to us about the differences in treating a patient with CRRT versus treating a patient with dialysis that presents like that.
So initially starting the CRRT program, we had some challenges at our facility with getting the docs to intervene and use it early. It was kind of thought of as a last ditch. It was very labor intensive, they thought. Administration is always worried about the acuity of the patient now becoming one-on-one and pulling a nurse off of a additional patient load. But what we've seen is utilizing it early and you get those patients hemodynamically stable off in a much quicker fashion from our trauma patients that initially require massive amounts of volume resuscitation. And you can prevent things like bowel ischemia, because, you know, I wish I had the slide that you had of the gross anosarca patient. I always tell everybody when the outside of your patient looks swollen and distended, that of course reflects directly on what all the organs on the inside look like.
That is so unappreciated by so many people.
Absolutely.
You know, the saying is anasarca is not simply a visually displeasing finding.
Yes.
What you see on the outside is what is on the inside.
Correct. So patients that, obviously a very large population of patients that we've utilized the ECMO and CRRT in, your flu patients, your ARDS who then, of course, deteriorate to multisystem organ failure, profound acidemia, we can correct them quickly with this versus emptying the pharmacy with 20 amps of bicarb and chasing your tail. And so we utilize it a lot in the CVICU for our patients, AKI, because they go into cardiogenic shock coming off. We have pretty high acuity patients that go in a lot of comorbidities, and we're able to kind of fine tune them immediately post-op versus letting them linger in the ICU on multiple drips, 10 different consults, and 10 days later, finally being extubated, making urine, and we don't want them leaving with chronic kidney disease if they didn't come with it from an acute injury.
Mm-hmm. Absolutely. Well, you know, creatinine is in itself nephrotoxic. And so, you know, John, John and Dr. Balan, you guys want to get involved in this a little bit, because the advantage I see of CRRT versus IHD in the acutely ill patient, and in particular those that are on ECMO, is that you don't have to correct everything within a very short prescribed therapeutic window, vis-a-vis 4 hours or 6 hours if you did extended dialysis. Even if you do SLED, it isn't continuous. And so being 24/7, much in the way the kidney works, and being able to change things more gradually but consistently, you don't have, you know, the concern of taking fluid off too rapidly and having that be a problem, or correcting the pH too quickly and having that be a problem, or changing the sodium too quickly and having that be a problem. What's your guys' experience with it? John, you're a big kidney guy, so what's your view of CRRT versus IHD for AKI?
Well, a vast majority of our patients on ECMO go on to CRRT. Mm-hmm. It's almost routine. If the patient doesn't have any deficient renal function, then they would not go on CRRT. But anybody that has even a mild implication of a decreased renal function ends up on CRRT. And the question I would have for Kimberlee is, can you explain the clinical picture that would determine if somebody was put on CVVH versus CVVHD? And I know you explained the small and large molecule difference, but what's the clinical picture of the patient that would decide which one we would do?
So our physicians, you've got normal acid-base balance, and you need volume removal and electrolyte fine-tuning. They'll put on CVVH.
Volume removal, acid-base management, and electrolyte.
Mm-hmm.
And what would determine CVHD?
Physician discretion.
Okay. So there's very, very minor difference between the two.
Well, if I can add to that too, if I may, CVVHD, and Dr. Balan, do you have any experience with this? Because if you do, I'll let you elaborate on this.
Not so much the specific question John is asking.
Okay.
I'll let you elaborate on that, but you did hit the nail on the head earlier. It really is, in most of these critically ill patients who have suffered hemodynamic collapse, it's the acid-base balance, it's the electrolyte imbalances, and the volume status that are critical. And that's where all of the things that Kimberlee has talked about are critical.
Yes, and doing it on a
Continuous
slower,
basis.
more continuous basis.
Exactly.
So CVVHD, John, is basically nothing more than dialysis, and it's a diffusive only therapy. So all you're doing is basically running the blood through the filter, running the dialysate replacement fluid, whatever you want to call it, through the filter countercurrent, going out into a waste chamber. And diffusive therapy is only going to remove molecules up to about $6,000. So it's very good for adjusting your pH. It's very good for electrolyte control and that kind of thing. But it does nothing for you in terms of inflammatory mediator removal. Most pro-inflammatory mediators live in the range of $15,000, $18,000 to $30,000, and you need a convective therapy for that. So convective therapy relies on the intra filter pressure to force the ultrafiltrate, the plasma water, through the pores, and the effluent pump is actually more of a dam than it is sucking across. So, and that's how you can kind of tell your filter is degrading, is when it starts becoming clogged, that positive pressure becomes negative, and the effectiveness of your filter sort of goes down at that point. But all you're doing is you're removing, because it is a convective therapy, much larger molecules, up to about easily up to $30,000. After that, it starts to trail down a little bit, but the maximum you can take out is $50,000, which is the pore size cutoff. So you won't remove plasma. If you have a patient that's in frank CIRS and they really require plasma adsorption therapy, well, now we're talking about a completely different game. There are some good studies being done right now that are using very, very, very high, ultra high, we call it effluent rate. So the typical that you see is between 20 and 25 mLs per kilogram of replacement. So the blood goes through the filter, ultrafiltrate off the plasma water. Distal to the filter, you replace the fluid. That's post-filter replacement, and that gives you the greatest clearance. Pre-filter, you're pre-diluting it, so you don't get quite as good a clearance, but you help keep your filter open, especially in patients that you can't anticoagulate. But we're going to have a whole session on CRRT in 2 months. And we're going to bring you back because of that. Remember, that's the program you're coming back for. Don't forget that. We need you back here. So I've got something, this is something you can study on, but then come back and you can school us. But with that said, the molecular adsorption therapy, well, they're doing very high volume, 20 to 25 cc's per kilogram of replacement. They're doing 40 and 45, even up to 50 mLs per kilogram of replacement. And that's a huge amount of plasma water replacement. But what they're seeing is they're pulling it out so hard, they're getting molecule sizes really bordering on 50,000 Daltons, and they're achieving a clearance of the pro-inflammatory mediators, and without molecular adsorption therapy, seeing good results. Now, you have a patient who has just completely, a gross inflammatory response. Nothing is going to help besides, a plasma adsorption, molecular reabsorption therapy.
The question I would have is, have they ever tried using a larger pore size filter with larger pore sizes?
Yes, if you use, but then you're going to remove plasma. Once you 55,000 Daltons is albumin. So once you start removing plasma, then they have those. They have filter sizes that are much larger that remove plasma easily without removing the solid blood components, and that's for plasma adsorption therapy.
Okay.
Right. So those filters do exist. They just aren't used in this. CVVH is more specific for the removal of plasma water and the replacement. And replacing it with plasma water that you want the plasma to look like.
The other thing I was going to ask Kimberlee is, I've worked as a traveler many different places doing ECMO, and I can tell you there's a place where I work where 100% of the time they go immediately to hooking up the CRRT to the ECMO circuit. Trying to have patient access is not even attempted. The opposite is true at other places I work. They do everything they can to get patient access and only hook to the ECMO circuit if they cannot get any other access. And I was wondering what they do at your facility with regard to access and which you would prefer.
I prefer going directly in line to the ECMO circuit, not waiting for additional access. I know immediately, and we work very closely with our perfusionists, so I don't know at the other facilities, is it nurse-run ECMO or is it perfusion-run ECMO?
Well, there's always a collaborative effort.
Okay.
But as far as who's deciding whether the access is direct or through the ECMO, that's coming from the CCM physician mostly,
Okay.
or the supervising surgeon. And in the facilities that go direct access, it's really a safety issue that they feel is overwhelming with the ECMO circuit because of the suck down issues that you have, air embolus sometimes that you have. And so I guess the experience at different facilities is probably dictating,
Yeah.
what their preferences are.
Yeah.
That's a very good point, as a matter of fact.
We haven't had any issues so far at our facility.
It doesn't mean we're not scared.
Yeah.
Okay, we are scared, and that is you bring up a very good point. You know, I wish I've not given that talk today, but I have a slide that shows the various different ECMO tools that can be used, and the tools that are on the market that you can buy off the shelf that have no ability to access the access of the negative side of the pump, in essence, the access from the patient, or introduce anything into it, just solid lines from out to in, are the ones that are advocated for use by the bedside nurse to watch the ECMO, like the CardioHelp, for example, or the what's the other one that they have? I think it's the Tandem Heart had one as well. The Centromag is another one. The ones that have access for drawing blood gases, for giving fluids, for rapid resuscitation, anything like that, it has to be, or the sort of the standard is a nurse ECMO specialist or ECMO specialist. I say nurse ECMO specialist, but ECMO specialist or perfusion. So that's the distinction there, and you're very, very correct in your concern. I'm concerned about it too. Every time we hook that thing up, I don't just turn that stopcock. I'm thinking about it, and thinking about it, and then thinking about it some more, and making absolutely sure, because I can't think of anything more horrible than to turn that stopcock while you have a patient who is ECMO dependent and hearing. That would be very unpleasant, at the very best. Dr. Balan?
In terms of my preference is to go in line with the circuit as is yours, and primarily it's because I want to avoid another stick on a patient. On many of these patients, we've used almost all the access. There isn't much left, and most of them are in DIC, profoundly coagulopathic. Last thing you want to do is stick them again. So running through the circuit is oftentimes best, but as you point out, Joe, you've got to be very careful.
Yes.
Anytime you're accessing the circuit, that's an opportunity for error.
Disaster, really, disaster.
Correct.
But another thing too is when you hook it into the circuit, John, one of the benefits, okay, so everything we do in medicine is a risk and a benefit. I mean, it's life in general, right? But in medicine, it's a little bit more perhaps thought about, is you have so much better flow. You can bump the blood flow rate to 400 cc's a minute. You're never going to do that through a Maherka or a Quinton.
Correct.
Your time for, when the patient's leg bends, and the next thing you know, your access catheter kicked. Now you're off therapy until they get that fixed. Got to call somebody in to reintroduce a new line. There's several advantages in terms of providing a really good therapy for the patient, uninterrupted, at much higher blood flow rates, because the more blood flow you have going through it, the more you're treating, regardless of what your effluent rate is. The more blood you can treat at any one time, the better off you are. And that's one of the big advantages of doing that, with the caveat that it comes with a greater level of risk.
The other comment I would want to know is when you get ready to discontinue the CRRT, or for whatever reason you're having to change a filter out, but you're going to be terminating, do you generally chase the blood in the filter back into the patient, or you just always disconnect and toss that blood away?
So I always try and stay ahead of my alarms. So if I see that TMP is rising, or PD is rising, or filter pressures are rising, then return that blood. With Prisma, it's only 190, it's like 187 that's in the filter. So you don't lose a lot, but obviously in a patient this sick, that's a lot for them, and we want to try and minimize additional blood infusions. So absolutely, always, I would rather return, even if it looked like I could limp that filter along a little bit longer, I would rather return that, give the patient back their blood, and change a filter.
Okay.
Agreed. Now, if it clots, obviously, if it's got clot in it or
Yeah.
whatever, we're not going to do that, but, you know.
But I've seen it both ways where they never chase the blood back in. They just figure there's a risk of, clot inside the filter or whatever, and they'll clamp it out and start new and start all over. And I've seen it where they chase it in. So it's an
I think
interesting
her
thing, because
point, and
even
I
if it's
think-
only 187 cc's, that's not too far off of a unit of blood. A
Yeah.
unit of blood is 225. or
Well,
so.
depending on the crit.
Yeah.
Yeah, right, but it's not the same crit, but it's still volume-wise.
Sure.
If you kept doing that every
Right.
72 hours, that's the longest your filter's gonna last, and maybe
Right.
less.
Sure.
After a while, you'd be probably having to give patient blood after a while. because
There's
you're
no
doing
question
that.
about it. You only have to give them more, because you're probably giving it to them anyway, but you certainly have to give them more. I think the difference is experience matters. Experience matters in everything all of us do. But again, we're talking about medicine here, whether it's doing a high-risk PCI, doing an ECMO insertion, doing a TAVR, whether it be crashing a patient on cardiopulmonary bypass that has a ruptured type 1 dissection, whether it, and dealing with that whole thing, or whether it's treating patients who are on multiple pressors, hemodynamically unstable with CRRT. Experience really matters. And what she said was, which is the take-home message, I think, for everybody, is I don't wait until the thing locks me out and says the filter is clotted. I can see what the pressures are. That's called being proactive. That's called being a professional nurse. That's called caring. I tell people this all the time. You can teach just about anybody to do just about anything. There's limitations, but by and large, you get my point. You can't teach anybody to care. You either do or you don't. And that's the difference. So you gotta have high level, highly skilled, experienced, professional, caring, mid-level providers at every corner caring for the patient to have a really good quality program. It takes everybody, from the quarterback to the people like me, the water boy. Everybody's got to do a good job.
What is your thoughts about the use of albumin, especially when you're trying to do volume removal? What are your
So I have a surgeon that loves it, and administration who wants to cut back on use of it. So initially in our fresh post-op patient, with blood conservation, we're going more towards albumin initially and large doses of it. In a trauma patient, you say albumin to a trauma surgeon, and he's going to ask you to leave his room. So it really depends on the patient. Again, how long did they wait to put them on? How sick are they? What did they look like beforehand?
What about in the middle of a ECMO run, not trauma patient, cardiac or respiratory patient, who blood lab results are coming back showing a below normal albumin level and a below normal total protein level? I've been on ECMOs where they still refuse to give albumin for days, even though the albumin level is below normal and the total protein is below normal.
And the patient's blown up like a balloon.
I would push for the albumin.
That just makes no sense to me at all. I've seen
Yeah.
that before too, and I've had people tell me that it is, it's of course, the Cochrane study. There's no outcome
long-term
difference, which I think was a horrible study, horribly flawed.
Yeah, this is something that needs to be more carefully examined, and the study that you're citing, Joe, is looking at long-term outcomes. when we're dealing with these very sick patients, it's not about the long run, it's about the short run.
Correct.
We're trying to get to the next hour, the next day. And yes, in the short run, the albumin does seem to make a difference. It's about oncotic pressure. You need to maintain oncotic pressure to keep things intravascular and to keep your connection from the patient's vasculature to the circuit running fully and appropriately. And if the albumin can help you maintain that intravascular oncotic pressure, you can keep your flows going and try to recover this patient. So yes, while there's no long-term data to support the use of albumin, in the short run, it certainly seems to make us feel better. And hopefully we can look at this better and look at short-term endpoints to try and prove that there is some value to using albumin.
John, what are your thoughts?
I remember in 1989, I was going to write a paper and we were going to change our cardioplegia, and I said to it's one of my first papers, and I said to the physicians, well, this will be great. We'll change the cardioplegia and we'll see if the patients actually leave the hospital sooner. Back then they stayed in the hospital 7 to 10 days. And I made a call to some people that were knowledgeable than I was at the time and said, well, you realize there's thousands of multifactorial things from the time the patient's admitted to the time of discharge. There's literally 1,000 multifactors there that are to determine what's going to happen to that patient. So you're going to try to keep all of those the same and change one item, one treatment, and determine if that ends up the reason why you would have to do 250,000 patients at least to be able to determine that one variable out of 1,000 things that are going to happen to this patient along the way made that be the reason why they were discharged a day earlier. So when you look at long-term survivability and you want to change one thing, giving a patient albumin in the hospital or not, and say those patients survive longer, you would probably have to do millions of patients, and they would all have to be a similar propensity score to make sense. So you can't, I don't believe you can do a study like that. You can't look that far out unless you're going to do numbers that are so impossible that, to determine it.
So I have two sayings that I'm very fond of, and I think you know the both. The first is absence of evidence is not evidence of absence. That's one. The second, there's never been a randomized controlled trial to tell us that parachutes work. So, there is anecdotal evidence. This world we live in now of evidence-based medicine has created this environment of the battle of the publishers and which industry is supporting at what level those people that are prolific writers, good researchers and very smart people, but very good writers and publishers. So if you write it and it gets accepted, it then becomes the standard, the evidence. And that's not always the best evidence. And that's the problem.
I can give you a third one to add to that I like. Mm-hmm. Mother Nature is far smarter than any of us will ever be. Mm-hmm. And the caveat to that is, you may be able to tell me that doing something other than the norm is beneficial, like for example running a high CO2 increase of cerebral oxygenation perfusion. So you may be able to tell me that doing something outside of Mother Nature is beneficial, but you'd be very hard to convince me that doing what Mother Nature wants is somehow harmful. So if you have a low albumin or a low total protein level and you do not want to bring it up because you don't think it's necessary, it's not going to help, well, there's a lot we probably don't know. And if you live long enough, you realize things that we thought were right even 10, 20 years ago, we thought we knew it all then, we found out that's not the right way to do it. And 20 years from now, we'll find out the same thing now. Mm-hmm. So if Mother Nature wants things in a normal level, I think we should strive to keep that until we happen to know for sure that somehow different is going to be better, which is going to be awful hard to convince.
Mm-hmm. 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 Or conversely to that having it that abnormal is not harmful. Because it can be either way.
It most likely is.
Things may not be better or not, but you also have to consider, is it harmful or not?
And just because you can't prove it in a study that it's not harmful in your particular study doesn't mean that it's not true. Mm-hmm. You just may not have been able to uncover it yet. Mm-hmm. Because I personally think low albumin levels are detrimental. You just said it, the short
Yeah.
term. And the short term is what we're sitting on right now, right? That's what we're looking at.
Well, have you ever seen this happen? You go into an ICU room, and the attending walks in, or their assistant fellow, whatever. Okay, how's this look? How's that look? Okay, that's good. And you want albumin? Why? Well, the albumin's 1.2. Well, yeah, but no. No, there's really no evidence to support that. Okay, go on. Blah blah. That looks good. Oh, okay. Patient looks good, and never looked at the patient with their eyelids hanging down over their cheeks and their earlobes swollen up like balloons. I don't need a paper to tell me that the ECMO pump flow the inflow is chattering, and the patient is swollen and looks like Jabba the Hutt, to convince me that there's a third spacing problem, and if the albumin is 1, we need to give albumin. An albumin of less than 2 is an independent predictor of mortality. So you look at, but that seems to be ignored. Okay, so any final thoughts on the topic of renal stuff?
I was just going to add one more saying, since we're in the saying.
Yes, saying.
John
saying
Maynard Keynes, the famous economist, once said, "In the long run, we're all dead."
This is
Not on my
very
shift.
true. In the,
I said, not on my shift.
Exactly. It's all about the short
but not
run.
on my shift. That's the best. Okay, you win you get the cup. The cup is yours.
Thank you.
You get the cup for the best line of the day, but not on my shift. Okay, we're gonna go off script. We're gonna take a short break. Let's just go ahead and do that now. We're gonna come back and we're gonna hit Dr. Balan's talk and then mine, and have a little bit leftover time for discussion after that as well. So I know I'm a little off script, but we got to do it this way. I hope y'all don't mind. And welcome back, everybody. We're going to jump right in to Dr. Balan's presentation. So, Dr. Balan, the floor is yours.
Let's go back up to the top of the talk there. If you could go back to the first slide for me, please. Are we having some technical difficulties? Yeah. Well, that's whole talk in reverse. So
That
there
was
you go.
I got it.
Yeah, and if you could go into
Oh,
presentation mode.
Here, let me see, hit the presentation button. There you go.
There we go. Thanks for having me this morning, Joe. We're going to talk about patient selection for VA ECMO. A couple of disclosures to start out. What is the purpose of ECMO? It's temporary support for heart and/or lung function for a reversible disease process in order to bridge the patient to something better. It is not a treatment in and of itself, but it creates an environment to allow us to treat the underlying problem. The goal of this therapy is oxygen delivery. It's all about getting blood, i.e. the oxygen carrying capacity of hemoglobin, circulating, getting an oxygen saturation that is up there at 100%, and using flow, cardiac output, and flow from the circuit to deliver that oxygen to the patient. What are the indications for VA ECMO? There are a number of them, and these indications are growing and broadening as we continue to learn. Obviously, failure to wean from cardiopulmonary bypass has traditionally been a reason to place patient on ECMO. More often now, what I do, I'm an interventional cardiologist, it's the cath lab crashes, the failed intra-aortic balloon pump. It's not enough support for the patient. I'll show you a case of that later in this presentation. ECPR, that is something that is becoming more and more common. Cardiac arrest is something in this country that is very common. There are probably 180,000 cardiac arrests a year in the United States. On average, survival is about 7 to 10%. With intervention, we can increase that number, and ECMO may play a very central role in that, and we'll talk about that as we go along. Many of the ischemic situations are important to provide substantial hemodynamic support. Valvular cardiomyopathies can also be situations. Joe mentioned a recent case of mine with a ridiculous gradient across the aortic valve, cardiogenic shock from the valvular cardiomyopathy, effectively. Right heart failure, acute pulmonary emboli, massive pulmonary emboli, we've used ECMO under those circumstances to bail patients out. Chronic pulmonary hypertension using ECMO as a bridge to transplant for profound right heart failure is certainly a valid option. Intractable arrhythmias, VT storms, ECMO can be used to bail these patients out. Even septic shock, profound vasodilatory shock, until you can correct the underlying cause, the underlying infectious cause, ECMO can provide the necessary support for your patients. Sudden cardiac death, as I mentioned, is a big part of what I do, and ECMO certainly can help under these circumstances. In terms of what you're trying to accomplish with ECMO, rapidly getting the patient on hemodynamic support allows you the platform from which to stabilize and thereby find the underlying cause and correct the underlying cause of the shock state. Conversion to a permanently implanted ventricular assist device can be done electively once you have that stability. In terms of providing cardiac support, if you're providing cardiac support alone, sometimes you've got to think about the health of the lungs. Many of these patients, as a result of the cardiac dysfunction, their lungs are full of fluid and they're not functioning well. You've got to think about providing heart-lung support, and sometimes that means going to VAV, and we'll talk about who's a candidate for that in just a little bit. So your goals with ECMO support, particularly in the setting of cardiac arrest and sudden hemodynamic collapse, is to protect the viscera, maximize oxygen delivery, rest the heart, come off of all of the inotropes, which are in many ways cardiotoxic agents, the dopamines, the epinephrines. Beating the heart with inotropes sometimes worsens, and there is data coming out to this effect, that actually worsens the long-term outcomes for the patients. Obviously, improving CNS function or preserving CNS function in the setting of cardiac arrest, hypothermia is a very valuable tool here, and of course that can be done directly through the ECMO circuit. In terms of the adequacy of your support, what you want to look at are some of the things that Kimberlee talked about earlier, bringing down the lactate level. Is there a urine output? Maintaining a mean arterial pressure, mixed venous oxygen saturations. And we'll talk about the needs for lung support as we go along. The idea here with ECMO is to provide a bridge to both diagnosis and treatment of the underlying cause. Your goal is to have a nice, beautiful bridge to somewhere, not put the patient on a bridge to nowhere. Now, here are some of the situations where ECMO can provide that bridge to a better place. Primary arrhythmias, as I mentioned, situations such as VT storm, and many of your non-ischemic cardiomyopathies, once that left ventricular end diastolic pressure reaches a certain threshold, the myocytes are thrown into a situation where they cannot repolarize and you trip off arrhythmias. You can use antiarrhythmic medications, but if you can't bail them out with your lidocaine drips and amio drips, you really need to go to hemodynamic support because you're going to lose the rest of the body while you're trying to control the arrhythmia. Massive PE, as I mentioned, is another situation that can cause complete hemodynamic collapse. The use of ECMO under those circumstances allows you to quickly and rapidly support the patient while you choose a treatment strategy. And as we know now, the number of treatment strategies are exploding. Catheter-directed therapies, surgical embolectomy are all possibilities here. Ischemic heart disease, a lot of what I do, patients who present with ST elevation MIs complicated by VFib, if they are in profound states of death and shock, oftentimes ECMO provides you that opportunity to revascularize percutaneously or otherwise, so that you can reestablish life. Structural heart disease, another big area of interest for me, particularly aortic valve disease. Absent support, sometimes it is difficult to have the time to get these patients to a definitive therapy, whether that is surgical, valve replacement, or percutaneous valve replacement. The cardiomyopathy space, also very important. The number of non-ischemic cardiomyopathies that we see these days are exponentially increasing. Some of these are acute myocarditis. These patients are very sick. They just need time to recover. And there are treatments for this. So if you bridge them to recovery with ECMO, you have a substantial chance of saving some of these patients. So thinking about the indications for cardiac support with ECMO, failure to wean from cardiopulmonary bypass, cardiomyopathies such as acute myocarditis, cardiac arrest, ECPR, cardiac failure, ECMO provides you that bridge to diagnosis, treatment, potentially recovery, and if there is not recovery, then to permanently implanted LVAD or even transplant. Other situations, massive pulmonary emboli with hemodynamic collapse, septic shock, arrhythmias, malignant arrhythmias, drug cardiotoxicity, and acute MI. Undiagnosed hemodynamic stability, and in many ways the reason I put this in is ECMO gives you the time to figure out which of these other potential causes has resulted in this hemodynamic collapse, and thus allows you that opportunity to treat and take care of these patients. Now, so far we've talked about the reasons to put a patient on. When should you not put a patient on? When you're dealing with irreversible or untreatable heart-lung conditions, there's no point in putting a patient on that bridge to nowhere. Severe vascular insufficiency, oftentimes patients with advanced vasculopathies are not going to be candidates for permanently implanted VADs or transplant, and therefore you should not put them on temporary support. Obviously, patients with major intracranial hemorrhage, it's an absolute contraindication. Severe or progressive chronic lung injury, these end-stage COPD patients, There's no bailout for many of these patients. Even lung transplant is not an option for many of them. So don't put a patient on who does not have an exit strategy. Irreversible processes such as malignancies and end-stage lupus. And just as an aside, in many ways I find lupus to be the worst disease possible. It affects every organ system, and I've seen too many young people pass away from this condition. And it's a great example of the kinds of irreversible processes that we cannot bridge with a technology like ECMO. Now, what are the goals of ECMO cannulation? You want to maximally drain the venous side and provide unobstructed flow on the aortic side without creating distal ischemia, particularly to the leg. Most often I use the leg. Having some technical issues here with moving this forward. You want to minimize the risk of infection to the patient, maximize the ability of the patient to recover, and individualize the treatment for each patient. You need to have a well thought out plan to accomplish this. There are many ways you can put a patient on VA support. Most often in the crash situation, that's going to mean femoral VA support, access the femoral vein, femoral artery, flow from vein through the circuit back to the artery. In terms of your sites, most often someone like me is working in the cath lab from the femoral. Typically when you do this, you've got to be careful of peripheral arterial disease. I make it standard at this point to place an antegrade distal perfusion catheter for all of these patients. You access the superficial femoral artery on the side with the cannula, point that sheath downwards and hook to the sidearm so that you create a circuit to perfuse that leg. Having an ischemic leg, a dying leg, saving the patient and losing the leg is not a reasonable option for these patients. You definitely want to save the whole patient. Now, some special circumstances. I mentioned the issues of lungs not functioning, venting the patients. One of the concepts here in cardiac support with ECMO is you're going to see a massive increase in left ventricular end diastolic volume and therefore pressure. What you're looking at here are the pressure volume loops from the left ventricle. When you place a patient on ECMO, as I mentioned, you are going to increase the left ventricular end diastolic volume as well as pressure. That shifts that entire pressure volume loop over to the right and produces basically a large increase in preload, a large increase in afterload with a loss of contractility. Essentially what you're doing is the opposite of everything you want to do to help a heart. Of course, that's buying you the time to help that heart, but essentially you're putting the heart in a really bad place. Venting that ventricle allows you to decompress that ventricle and therefore not harm it in the long run. And there are a number of ways that you can do this. It can be done surgically, the LV can be vented. From a percutaneous standpoint, frequently we use the Impella device that can allow you to unload that left ventricular end diastolic volume and therefore pressure, and thus move that pressure volume loop back down and to the left so as to unload the ventricle. Now, keep in mind, VA ECMO, it's great for cardiac support. However, if you've got lungs that are not functioning, you're going to run into serious problems. Specifically, if you've got lungs that are not capable of oxygenating or ventilating, you're going to get blue venous blood that's going to circulate from the right side of the heart back to the LV through those non-functioning lungs. And if that heart is ejecting, what it's ejecting is blue blood to the arch vessels. And therefore, what the brain is going to see is deoxygenated blood. You're going to end up with what's called differential hypoxemia, informally sometimes called north-south syndrome or Harlequin syndrome. The way to address that, one way to address that, is to simply go to VAV ECMO, widen that arterial cannula, and return oxygenated blood to the right side so that what the heart is ejecting is in fact oxygenated blood. Now, the tools needed for rapid percutaneous placement of patients on ECMO, fluoroscopy, ultrasound, echo, skills with catheters and guide wires. We were just talking about the importance of being facile with catheters and guide wires. It is absolutely essential in the ECMO space that surgeons and interventionalists have these tools in their toolbox. In terms of goals from a flow standpoint, for an adult, you want to see 50 to 75 milliliters per minute per kilogram. Your goal, as we said, is max oxygenation using both the pump and any native flow that the heart is providing. Some pearls of wisdom that my mentors taught me: in an emergency, move quickly. You can make adjustments later. With your arterial return cannula, it's better to err on the side of being too far in. The last thing you want is for that cannula to come out. I've seen that happen, and it's truly a bloody mess. On the venous side, go big. Okay, most people's veins are distendable, and you can put a 24 French cannula in there. Your goal is to get maximum drainage on the right side. That will maximize your flow in the long run. You can cannulate quickly under local anesthesia. Frequently, when we're doing high-risk procedures, we keep sheaths on reserve just in case we need to go on. I always have one extra 5 French venous sheath during a MAC anesthesia TAVR, whereby if I have to go on, I have that access in place. And as I said, use the right tools. Frequently, these are crashes happening out in the field, and I'll show you a picture of that in a moment. However, if you have the assistance of fluoroscopy and ultrasound, do these things with eyes. Do it with guidance. I'll make a quick segue into eCPR here because this is an important subset of what we'll be using ECMO for in the setting of cardiac support. This is an area of large research interest for me, and as I mentioned, cardiac arrest is ridiculously common, and we see a lot of young people dying from this. Use of ECMO in this space can certainly improve survival. You can use VA ECMO for ongoing CPR ACLS. It is best to do it in patients who have a reasonable chance of survival. That is, patients who suffer a witnessed arrest, have the opportunity to receive immediate CPR.
Point it towards the, there you go.
CPR that's short in duration, CPR of less than 30 minutes. It is oftentimes best to use it in patients who have an initial rhythm that is shockable, VT or VF. Your outcomes are not as good when you have PEA or asystole. Younger patients tend to do better than older patients. Basically, you want to take those patients who have a reasonable chance of survival because they have a reversible or treatable cause for their cardiac arrest. You need rapid percutaneous access and aggressive evaluation and treatment for these patients. Is there data for doing this? Absolutely. This is from a study done by the group at the University of Minnesota, where they took about 145 consecutive out-of-hospital cardiac arrests with refractory VF, put them all on percutaneous ECMO in the cath lab, and then revascularized the coronaries. They saw a survival rate of about 45% with this. They compared that to a historically propensity-matched cohort where patients were treated only with ACLS. The survival there was 15%. So that's a massive improvement in survival from 15% to 45%. With basically eCPR and immediate revascularization. So there is a place for this technology in the cardiac arrest space. This is a picture, as I mentioned. We're going to be doing a lot more of this, I think. This is from the floor of the Louvre in France. This is from late 2017. The Europeans are way ahead of us in this regard. It's a portable ECMO team cannulating a cardiac arrest patient on the floor of the Louvre and then transporting to one of their level 1 centers. In terms of eCPR management, your goals are to drain the heart as quickly as possible, treat any malignant arrhythmias, eliminate those toxic catecholamines, the dopamines, the epis, and get them to the cath lab for urgent revascularization. As you do this, you need to protect the brain, cool as quickly as you can, and then protect the viscera by flowing at high rates, high flow rates, protect the liver, protect the kidneys, protect all the other vital organs. From a brain standpoint, Hypothermia has shown significant advantages in terms of neurologic recovery. And then from the standpoint of saving the body, as we mentioned, maximize flow, bring that lactate level down, watch your liver function numbers, hopefully get those down as well. Use CRRT, as Kimberlee elegantly described, to support not only the kidneys themselves, but the overall electrolyte balance for the patients and acid-base status for the patients. Get these patients fed quickly, as we were talking about. Having oncotic pressure is very, very important, and keeping the GI tract alive and going with enteral feeds is very, very important. From the standpoint of the rest of the body, apart from vital organs, the periphery, the extremities, protect those extremities. There's no point in saving a life, or maybe a point to it, saving a life at the expense of the limb, but if you can save the whole patient, go ahead and save the whole patient. And if that means putting in that antegrade catheter, which I think should be uniform, even if you've got giant vessels and you think you can flow around that cannula, do it anyway. Once these patients get into states of hemodynamic compromise, oftentimes even big vessels clamp down. They clamp down around that cannula and you lose flow. Therefore, providing that flow through the circuit with an antegrade perfusion catheter is vital. Whoops, went ahead of me a second there. Let's talk about a couple of cases to illustrate some of the concepts that we've just talked about. This is a TAVR patient that we treated just last week, actually. Young woman, 64 years old, and this is how we present patients in our valvular and structural heart disease conference. Multiple comorbidities. Basically, she suffered from myasthenia gravis with myasthenia crisis and morbid obesity. This lady could hardly move as a result of her myasthenia. Therefore, the surgeons deemed her at least intermediate, if not higher risk for an open surgical AVR. She had severe aortic stenosis, mean gradients that were measured by echo at about 50 plus millimeters of mercury, no significant coronary disease, and reasonable but highly calcified access. And there was some degree of peripheral disease. You can see those external iliacs on the left were relatively small. The plan for her was treatment with a 23 millimeter balloon expandable prosthesis. And as we went ahead with that intervention, we did run into some difficulties. Here you see the original aortogram at the start of the procedure. She has clean coronaries. However, you notice the right has a particularly high anterior takeoff, the right coronary artery there. The valve turned out to be quite a bit tighter than we anticipated. Even a simple valvuloplasty balloon, a 20 millimeter valvuloplasty balloon, would not cross. So we actually took a 10 by 40 peripheral balloon here and put that across the valve to create an initial valvuloplasty to serially dilate up to get our valve across. Immediately after this valvuloplasty, the patient fibrillated. One defibrillation, we got her back, and she was maintaining her pressure at that point. We were then able to dilate with a larger valvuloplasty balloon, and then ultimately bring our valve across and smoothly deploy the balloon expandable 23 millimeter prosthesis. At this point, we again had VF, and when we take our aortogram, something's missing.
Yeah.
That right coronary artery doesn't appear to be there at this point. The EKG is showing us ST elevations, and now we're getting hypotension as well, 80s over 40s. She's looking truly shocking to us. And as you can see, something has gone down that proximal right coronary artery. There is clearly a filling defect there. We did look at it by intravascular ultrasound. My suspicion is calcium from the valve itself embolized down the coronary artery. We were able to engage the artery, wire it, balloon, and stent the artery, which did take some time, but we did it all on ECMO support. Given the hemodynamics instability, the VF arrest requiring defibrillation, the low mean arterial pressures, we did all of this on VA support. 17 French arterial cannula, 23 French venous cannula. We had the stability to go ahead and do this intervention. It was not easy to engage this artery with the valve right there and the high anterior takeoff. However, VA ECMO provided us that opportunity to bail this artery out. Without that support, there would have been ongoing hemodynamic crisis. Ultimately here you see the final shot of the right. We were able to repair that. Excellent valvular function. We left her on VA support for 2 to 3 days as she recovered from the shock state. She came off VA ECMO 2.5 days after initiation, bridged out from there on a balloon pump, which is now out. The patient is now extubated off of all hemodynamic support, off of all pressors, is now doing physical therapy. Her EF is fully preserved. Second case, young gentleman, 51 years old, some risk factors, particularly diabetes, comes in with tombstones, high anterolateral ST elevation MI. There's the initial angiogram. You can see the LAD is cut off, and you can see there's a severe lesion in the proximal circumflex as well. And most likely that was not just a bystanding chronic lesion. It's actually somewhat hazy in most of these views. You see it in the LAO view here, that there truly is a hazy stenosis in that body of the circ. Of course, now, I started with a balloon pump here. This was very early in my career. This is a case from 2013. And that shakiness that you see in the image is CPR. We bail out the LAD as quickly as we can. But now notice, we've got the LAD back, we've lost the circ. So then you get more CPR as we're trying to bail out the circ here. And we get the circ back quickly, but you can see this is a very unhappy heart. We get him on VA ECMO, and that gives us the time to recover this patient. We get him up to the ICU, 4 days on support. He comes off, transitions beautifully. Ultimately, 5 years later now, 6 years later now, this gentleman still follows with me in clinic, completely preserved ejection fraction. Without the ECMO support, we would have been lost in a tunnel of VF at the end of this case. Even though we'd gotten the coronaries back, ECMO gave us the time to bail him out of the recurrent VF VT that we had at the end of the case. So with that said, I just want to acknowledge my mentors. I want to thank Mike Hines, who taught me most of what I know about ECMO, as well as the ExtraCorporeal Life Support Organization. Thank you.
Excellent talk. Very, very good. So you brought up a lot of very good points, and again, I'm going to go off script, and we're just going to open this up and have a discussion before I do my presentation. Mine is on cannulation strategies, and I copy a lot of things that you were talking about. Maybe talk a little more about exotic cannulations, but I'm really wanting to focus on your point, and I'm bringing this up because I was told this 3 weeks ago by an intensive care medicine doctor. ECMO has never saved anyone, and he doesn't think it should be done for anybody. How would you reply to that?
I vehemently disagree. I have a clinic full of patients that are survivors from cardiac arrest that I've bailed out with ECMO.
Mm-hmm.
That we as a team have bailed out with ECMO. It gives you, as I mentioned in one of the early slides, it is not a therapy in and of itself. It is a support that one uses to provide the appropriate therapy, and even gives you the time to make the diagnosis. Okay. In that TAVR case that I just showed, initially she VFs, we have no idea what's going on. We don't know why this patient is fibrillating before us. Why is she hypotensive? Why is she shocky? It took some time we did a ventriculogram, we did an aortogram, we engaged both the coronaries. All of this is taking time, and the patient is in profound shock. Putting the patient on support gives you the time to figure out why this patient is crashing and then go about fixing it. As I said, this was a very high anterior takeoff. I remember when I did the diagnostic cath for this patient, I had trouble engaging that right. Now with a valve in there in shock, I have to re-engage that thing with a guide. I need the time to do that. And ECMO provides me that time and that support, keeps the patient going until I can fix the problem that's creating the hemodynamic collapse.
And I think you brought up the key, the takeaway message that I'm trying to get out there, and that is patient selection really matters.
Right.
So I think that what happens, and you've seen this in your career, they put an already deceased patient on ECMO and then wonder why the outcome isn't any better.
Right.
And that's the issue. And with this recent, we had Matt Warhoover was online last night, and that case you're talking about, that one that you just did, but that was Brianna from last night that was the perfusionist, right?
Correct.
That was our Brianna.
It was a team effort,
that
exactly.
did
She
that
did a great
case.
job.
Good. Brianna, if you're listening, shout out from Dr. Balan, okay? Great job on that. But he was on, and of course, there's this big problem right now with ECMO reimbursement. I don't think it's going to stay like that. There's no way you could justify $8,000 as a
Correct.
reimbursement for a VA ECMO for a patient that hits your emergency room with refractory, lethal arrhythmia. But how do you discuss the reasons why that happened? That there is an abuse in the system. There is a utilization of the tool improperly, perhaps not for nefarious reasons, just as a result of a lack of education, a lack of knowledge.
In terms of appropriate patient selection, we do have to choose the right patients for this therapy. There has to be that reasonable chance of survival. Absent that, you really are on that bridge to nowhere. Okay. And particularly, that's why I went into the ECPR stuff a little bit, because that's a context where, if the patient is truly cold and dead. I once had a case, was called down to the emergency room. Gentleman was part of the cleaning crew at the Astrodome.
Oh.
Okay. He was found on a Saturday morning in the stands down. The last time he had been seen was cleaning up after a Friday night high school football game. He was probably dead for over 12 hours.
Yeah.
There's no point in doing anything for that patient. He is deceased. On the other hand, a patient like the one we saw, the last case that I mentioned, did another case recently, 49-year-old running the marathon. About mile 6, he has chest pain. He calls his wife and says, "I'm having chest pain." She tells him, "Don't call me, seek medical attention." Luckily, he's on the route of the marathon. There's medical attention all along the route. He collapses in front of the medic, gets immediate CPR. There's an AED there. AED reads VF. And as I mentioned, the chances of survival when it's VF or VT are exponentially greater, 17 times greater than when you're dealing with
Wow.
PEA or asystole. Okay, that's been documented. Younger age. This was a 49-year-old South Asian gentleman. Hit home for me because I'm a 49-year-old South Asian gentleman. Immediate CPR, shorter runs of CPR, as in if you're under about 30 minutes, your chances are better. That 49-year-old, unfortunately, it was about 60 minutes of CPR, but we bailed him out. Immediate hemodynamic support, revascularization, guy's fully neurologically intact. It was a long CCU run. However, fully neurologically intact and now rehabbing at TIER. So some of the factors that I outlined, younger age, witnessed arrest, immediate CPR, short runs of CPR, those are the kinds of things that favor survival. And we've actually been able to show this. We've used a Houston Fire Department database, over 15,000 cardiac arrests,
Wow.
and been able to validate these simple factors as predictors of survival. Patients who hit all of these markers have a 90% chance of surviving sudden cardiac arrest. Whereas if it's an unwitnessed arrest, no immediate CPR, asystole, they're nowhere near medical help, they're older, your chances of survival are in that 7 to 10% neighborhood. It may not be worth it. And we need to make those choices. We need to decide up front that there is not a reasonable chance of survival here. Let's not go on. On the other hand, that 49-year-old with a teenage daughter, that's the person you throw everything at because he's got a shot.
Yeah, if you're 95 years old and,
Right.
regardless that you still work in your garden, and look, I mean, I've got a 99-year-old mother. We all have moms, right? I mean, and I certainly can understand the visceral, anguish of a family, but I'm going to kind of throw hardball question at you, and it's a tough one, but it's, I think, a reality. You put the patient on ECMO. When is enough enough?
My threshold is 4 days. If I do not see a chance of reasonable
On
recovery.
VA.
On VA
For
ECMO.
VA, not
Okay.
VV, no.
I've had those cases, and I actually thought about putting in one of those cases just in the interest of equal time. I showed you some great saves. There are a lot of these that are not great saves. The data from that University of Minnesota study was 45% survival. It means the majority of these don't make it, okay? If at 4 days you have no neurologic recovery, you've got a patient with cerebral edema and anoxic brain injury, your chances of making it out of that are slim to none. And yeah, you've got to turn it off. At that point, you're just flogging literally a corpse.
Well,
It's
we've
not the right
seen-
thing to
we-
do.
You know, it's not, but we've seen that happen. In my own practice, we, both Kimberlee and I have the same experience, and these are well-meaning physicians. But it's hard, it's very tough to say, you know, I'm gonna turn this off. But, you know, and some of the patients, I mean, remarkably, I was confident they were not going to get off ECMO. Now, if they got off ECMO, they didn't go home. They got off ECMO. You know, and I am torn with that. You know, who, you know, elected me, you know, overseer of ECMO. You know, I mean, I just, you know, we're there as facilitators and there to provide a service. We're not there to make those kinds of decisions. But at the same time, we have to understand that there are limited resources, and if we use the resources up on an 85-year-old, again, notwithstanding they were playing golf and they were having a good life, we don't have the resources for the 49-year-old, and that's where the problem is.
We have to make difficult decisions sometimes. If we have to make those decisions up front, I'm trying to find the right sets of data on which we can make informed decisions. If we choose to go on, there is a point in time where I think we have to reevaluate. And I don't know why I've chosen 4 days, but in terms of the playing out the neurologic piece, I think that's where it comes from. By 96 hours, I have a pretty good idea of where this is headed from a neurologic standpoint.
Well, even if you're neurologically, and guys, please jump in, okay? I mean, I don't mean to monopolize. I do that a lot. I get criticized for it sometimes. Rodell, in case you're watching. You may have, the patient may be neurologically intact. They might be looking around and, you know, and you're snowing them. But their heart is never going to recover, and they're not a candidate
Right.
for anything. And their kidneys are gone, but they're living off of CRRT. We can make you look great. We're good at that. But once all of that's withdrawn, there's nothing there. So you're not a candidate for transplant. So your heart is not going to recover. It's not moving. It's gone. Your kidneys are gone. Your LFTs are on the rise, but you're neurologically intact.
That's not a meaningful life. So sometimes you have to make that bridge to decision. And that's really what this is. You get to that point a few days in where you realize even if that patient's awake and there's no chance of reasonable survival and there's no exit strategy, for the heart, if there is not the opportunity for a VAD or a transplant, you have to stop.
I think you're right. It's tough. It's tough, you know, because we are, you know, you know, we repress our emotional. It's why we're all so weird. You know, medical people, we're all crazy, you know, for a reason.
None of us is God. None of us can play judge, jury, or executioner here. We make the best decisions we can under the circumstances. And then we use the judgment of not just one individual, but multidisciplinary teams. And I think here, you mentioned mid-levels and so forth. I view it, we're all a team. Everyone's got to work together. Everyone's opinion is valuable. Everyone's perspective provides insight. And as we make some of these difficult decisions, it takes the heart failure specialist, the interventionalist, the surgeon, the perfusionist, the nurses, all of us have to put our heads together to really find what's right for this patient. We have to work together with the family and the patient. And I oftentimes rely on what would this patient's wishes have been under these circumstances. And I talk to spouses and children and ask, did they ever confide in you as to what they would have wanted if they were in this situation of extremis? And sometimes you do find out that, you know, mom really wouldn't have wanted any of this.
Well, I'm going to tell everybody right now, for the record, everyone at this table, everyone in the audience, and everyone out there on the web, I don't want it. Okay, okay. When it appears I no longer have meaningful life, John, Kimberlee, pull the plug.
Yeah, very good. Myopathy is exploding the way it is.
I think it has a lot to do with the American food industry. Have you ever looked at the numbers in terms of sodium in anything that's any processed food in this country?
I'm a big sodium person, yeah.
Yeah, it's a problem. And I do think that for certain populations, the ability to handle or manage that sodium load, they don't do well with that. And as a result, end-stage hypertension, it creates extraordinary renal damage, it creates extraordinary damage for the heart. It's truly a catastrophe. And what's sad about it is, in some ways, I think we're doing it to ourselves.
Do you think that IV drug abuse is a role in as well?
I do think so. Again, another sort of self-injurious process whereby many young people we see with these kinds of self-induced cardiomyopathies as a result of a variety of toxicities.
In terms of something you were mentioning with ECMO, you were saying with Fem Fem ECMO, you almost invariably have LV distension. You were showing how the curve shifts to the right. We see that, and a lot of the approach is sometimes to put an Impella in, but the first approach is usually to turn up the flow in the hopes that you're draining the right atrium more.
Correct.
That doesn't always work, but it sometimes works, but you still have the paradoxic influence that you're flowing retrograde up the femoral artery directly at the aortic valve, which even if it's not regurgitant, is resistant to an already weak left ventricle, probably couldn't eject very well in the first place, which is why they're on ECMO. So do you aggressively treat the LV distension, quick to put, say, an Impella in, or?
Actually, not that often. Oftentimes, treating the underlying cause of the LV dysfunction quickly gets you back to pulsatility, allowing the native heart to unload itself.
You're talking pharmacologically, too?
Pharmacologically, yes, to some extent, but like I said, I want to avoid those high-dose inotropes. Yes, the lady with the TAVR case we mentioned, I did have her on a low-dose 2.5 dopamine, just to provide that little bit of inotropy, to provide some pulsatility to help unload that ventricle. I did not put her on an Impella, simply because I didn't want to shove anything through the freshly implanted valve that I had just placed. So it is not frequent that I have to use the Impella as a vent patient, so that you have an idea of what is that wedge pressure, which reflects that LVEDP for you. And if that is beginning to mount significantly, that's when I have that threshold
Oh, I see. So
to
you're
go
watching
to.
your wedge pressures. Okay.
Exactly. And if I'm seeing a non-pulsatile LV in the setting of rising wedge pressures, that's my threshold to go to a vent, the percutaneous.
Combined with the analysis of an echo, I would think. Yeah.
Correct. But if they're pulsatile, if they're able to eject and they're showing me that they've got that shot at recovery, I'll wait. You really don't want to introduce another large bore cannula if you don't have to in these patients that are critically ill, have vascular access issues, are coagulopathic.
Well, I made this comment yesterday or last night. I think the Impella is a good tool, but I think it's like many other things, it tends to be over-marketed and overused. And I think that it has a place, just like ECMO has a place. It's like TAVR has a place. Everything has an appropriate place. Heart surgery has a place. So I think that our mission is to use it appropriately as best we know how, as best we understand what appropriate is, right? That's what I think the real goal is.
I want to talk about something. You said you had an email or text 3 weeks ago from a CCM doctor that said ECMO should never be used, and no
It
one.
wasn't a text, no, it was a face-to-face
Oh, okay.
conversation.
That, no,
It was a
basically,
People have
face-to-face
those these days.
Yeah. Exactly.
but his opinion was, or his experience was, his or her, that no one gets better on ECMO. I actually heard that, my exact quote myself, just about 2 weeks ago from a clinical educator from one of the device companies that has something to do with ECMO. And she actually said, no one ever gets better on ECMO. It's just buying you time to get somewhere. Well, that's not true. I see people getting better on ECMO all the time. But the time that you're afforded is the reason why they got better. You know what I mean? That is the reason. They needed that time to experience rest, recovery, or treatment, or
Sure.
all three. So if his experience or her experience was no one's getting better on ECMO, in their particular hospital, they're putting people on way too late. So,
Well, that's-
yeah,
that's
no one
true.
is getting better because they didn't have a chance to get better
That's
in
VA
the first place.
and VV. I totally agree with you. You know, I mean, we've talked a lot about VA ECMO, which really should have been the thrust of your talk. Mine's going to be more geared towards VV, but also some exotic cannulation strategies. But even with ARDS, secondary to pneumonia or whatever it may be, if you have the patient on a ventilator for 7 days at maximum ventilatory support with peak pressures of 40, 18 of PEEP, 100% FiO2, and still and having been satting 80 to 85% for the past 7 days, come on, that the lungs are no longer recoverable. You know, you can't do that to them and expect them to be able to get better. So the problem becomes, people will argue, you put the patient on early. These are people who disagree with ECMO. You put the patient on early when you see it going that direction. They get better, transition off of ECMO, and ultimately do fine. Their argument is, you put it in too early, they would have left the hospital anyway. They would have gotten better on their own. And I have had these arguments with people multiple times, and it's just like, it's almost as bad as albumin. You know, the albumin is 0.5. You know, and we have 0 intravascular volume left. But oh no, albumin is of no value. Just give more saline. So you give it and it's gone before it has an effectiveness of 5 minutes at best. You know, and just liter after liter after liter, and the next thing you know, your patient's 35 liters overloaded, and they're not going to survive. Well, then, no, they're not going to survive. So then they decide to put them on CRRT, and then they don't survive, and they say, look, CRRT doesn't work. You know?
You can't have it both ways. You can't say that we put it on too late, so we never should use it, but then we put it in and it was too early, we shouldn't have used it. You have to be on one side or the other. If you believe we're putting it in too late, you're going to have an occasional time where maybe you didn't have to put it in, but you did. I mean, there's a little bit of a price to be paid for success. You know, it's not free. So maybe 8 or 9 out of 10, you did put it in early enough, and they did survive. And maybe that one, you know, you could maybe say, but you're armchair quarterbacking. Even if you say we put it in too early and we didn't need to, you're still armchair quarterbacking. You don't know that. You must have felt something serious enough to put it in, right? So you have to be on one side of the fence or the other. I don't think you can play both sides, and then you're in no man's land. You never
well,
put it in ever.
If you're an intensivist, you can be. You could walk both sides of the fence. That's what they did. That's what they, no, if you're an administrator, you can really straddle them. You can straddle the fence even with razor wire and scoot along on it. They do just fine with that. Okay, you want me to get my? Let me get my talk out of the way, and so that we don't run over today like we did yesterday. So ECMO cannulation strategies. Can I borrow the clicker?
Absolutely.
Thank you. Okay. Does anybody know what's the heck's going on here? It's not working. Just go to the next slide. Next slide.
Probably the battery's getting weak.
Yeah, probably
Battery.
so.
Yeah, that's what I suspect.
Okay, does anybody know what this is? If anybody can tell me what this is, whether even on Web World, if you type it in, you win a stylish PerfWeb coffee mug. Okay, you'd love to have your coffee in that this morning, no doubt. Anybody know what? Okay, it is you know what it is? No, camera 2.
Okay.
Yeah, right here. It is a CPU processor. Next slide. Anybody? Oh, here. Am I doing that? Oh, it's not. This thing does work. Okay, it's me.
lucky.
It's user malfunction. Okay. Does anybody know what this is? These are brain neurons. Okay. Anybody know what this is? This is anybody? Julie? You know what it is? Dr. Balan? I mean, Kimberlee? Yeah, same thing. It's an E. I got the E part. That is an oil field directional drilling site with all of the pipes laid out in graphical form. Okay? And anybody have any idea what this is? You get this and you win 2 cups and a free webinar.
Nuclear power plant? I don't know.
Any guesses? Nuclear power plant? That's one guess.
No idea.
No idea. That is a rocket engine.
Oh, wow.
Okay. Now we all know what this is. Okay, so we don't need to tell anybody what that is. The cardiovascular system, obviously. What do all these things have in common? Well, we put a crack team of specialists together, and we concluded that they are to transport something from one place to another. In the first and second examples, it's electrical impulses from point to point. In the third example, it's oil and gas from reservoirs underground to storage tanks. In the fourth example, it's mixing hydrogen and oxygen properly so you get you get propulsion and not an explosion, or you get a controlled explosion, more appropriately. And in the fifth example, it's blood and oxygen from one place to another and under the right pressures. So this algorithm, and Dr. Balan, you've seen this, you have a similar algorithm. What do you do? How do you decide whether to put somebody on ECMO or not? Well, there is a lot of data and algorithm design. So you have refractory hypoxemia, a Murray lung score of 3 to 4. If you have cardiogenic shock or you don't have cardiogenic shock, which you're looking at here, is the pathway you're going to take. In this case, you're going to go to Venous ECMO. In this case, you're going to come down and you're going to have, is it other heart failure, or is the cardiogenic shock itself due to hypoxemia? If it's other heart failure, you go to veno-arterial or veno-arterial-venous ECMO. If it is due to the hypoxemia itself, then you go to veno-venous ECMO. So these algorithms are very simple. They're easy to look at, easy to understand, and should be easily followed. Okay, try it again. Click it. Okay, so the classic indications for mechanical assistance are bridge to recovery, bridge to bridge, bridge to transplantation, and destination therapy. But now in the acute setting, bridge to whatever seems reasonable, including withdrawal after a few days if refractory multi-organ failure, or there's obviously no chance of survival. So to dive a little deeper, VA ECMO, cardiogenic shock with about MI, myocarditis, you can read these yourself, but these are basically, I think going to the second to last one, bridge to decision for either transplant or VAD or nothing, which I didn't put in there, but should be there, is something to be considered. Most common forms of VA, when it is an emergency, is, as you see on the left, percutaneously femoral venous to femoral arterial. You also, in pediatric cases, which is the center, you have the right jugular vein and you have the carotid artery, which is sacrificed in this case. And then furthest to the right, you have central cannulation. Here is an image of central cannulation. Now, on the left here, what you see is a drawing of it. And what you should notice from this drawing is that it appears that the heart actually fits in the mediastinum. You also notice that when they put this patient and probably a transition off of cardiopulmonary bypass, they tunneled the catheters through the inferior portion of their incision and then brought them up. Now in this case, you see the arterial cannula coming up here and going into the aorta. So looking over here, you notice this heart is huge. It's edematous, it's distended, this does not look good. This is not normal looking at all. But you see that they've tunneled these cannulas in, and they have a venous access catheter that's coming in and going to the right atrium. They have the arterial cannula, and what they've done is they're bringing it around the lateral aspect of the heart, bringing it into the aorta here. The reason they did that is because look at how big this heart is, and if this is over the top and they want to approximate this chest, one, it's going to get in the way, and two, I have actually seen this erode through the ventricular wall, and that's quite problematic. It's usually not recoverable. And then over here, you have a right superior pulmonary vein cannula that is being used to decompress the left side of the heart. So there are multiple ways to do that. I'm going to show you some additional ways besides, for example, Impella, to keep the left side of the heart completely decompressed. This type of configuration is going to give you very good drainage. Here is not that particular patient, but another patient, and you see here where they brought the cannulas. This is central cannulation. They were able to approximate the chest. This is hugely important when it comes to getting the patient to the ICU and controlling your bleeding, because when the chest is left open, it is a bloody mess. Not to mention, yeah, of course, they put the backpack on it, but they leak too, and it's just a more aseptic way of managing the patient later, and you can turn them more easily. There's a lot of things you can do. So let's take a look at some real common configurations. This, again, on the left side is typical Veno arterial ECMO with peripheral percutaneous or cut down cannulation. Here is, and you're coming from the femoral vein with a long cannula. You usually want to advance it all the way into the atrium. I don't like it when it sits down low like this, especially if you do use an oversized cannula to get better flow. Sometimes the venous system will collapse around it a lot easier, and smaller cannula may be better. But if you stick it all the way up to where you're at the SVC right atrial junction, you really get very good drainage at that point in time. But you got to take the time to do it, and imaging matters if you forget to measure it as best you can. Then arterially, of course, going into the femoral artery. Here you have coming from the right atrium, going usually through the right jugular, going into the subclavian. It could be out here in the axillary. So this is really not considered central cannulation because the chest in this case is not open. These are still put in percutaneously. Here is an example of draining from the inferior vena cava, draining from the superior vena cava via the right IJ, back to the pump, through the pump into the oxygenator, out of the oxygenator, back into the femoral artery. So this is an example of VV ECMO. And again, you know, one of the big limitations that you can have with VA ECMO, and it's a great tool, but when you don't have enough flow and your drainage is bad, it's very frustrating. So access really matters. You know, I say that the key to success with ECMO is access. There's three keys: access, access, and access. And that's the same with CRRT. It's with anything, really. Any extracorporeal blood therapy, access really matters. In this case over here, you have access, but you have this. So this is VA coming into the subclavian and A coming into the femoral artery. So this is an example of VAA. Now this is very good if, let's say, you put the patient on peripheral cannulation bypass with a very small arterial cannula, and you don't want to change that out you go ahead and introduce a line into the subclavian, and now you've given yourself 2 cannulas that's going to reduce your flow, your resistance to flow through the ECMO, improving it, or should improve it. It's also going to reduce your opportunity for dual circulation or Harlequin syndrome or north-south syndrome, or whatever you want to call it. Let me show you these various different things to show you how exotic, and I'm not going to go through all of them in terms of following them out. We have Veno to arterial. This is another example of Veno to arterial. This one you're using the inferior cava and the superior cava, and you're coming and going back to the femoral. In this case, you're using both femorals and going back to the going back into the femoral artery. Here's VVA, where you're coming superiorly and you're going back to the femoral artery. Here's VAV, so one vein to vein, artery, vein. So this is very good for a patient, for example, that has cardiogenic shock and bad lungs. So you're taking from the vein, returning it to the femoral artery for mechanical support, but you're also returning to the right atrium to help supplement what the lungs are unable to do. So blood that does shift over to the left side through the pulmonary circulation will be oxygenated, and you're reducing that risk again of Harlequin syndrome. In this case, you have vein to artery and vein. So here is your venous access is coming from the IJ. Your return is going also back to the IJ and the femoral artery. So it's the same thing, just with different vessels. And remember what I said. It's about getting blood, whether it be neurons or what electrical impulses, or whether it be doing oil and gas, or whether it be mixing hydrogen and oxygen to get your rocket ship to space, or you're on ECMO. You have to think about the circuitry, the pressures, the flows, the way the whole system works. These are all closed systems, but they're dual systems, and you have to figure out how to make these things work in synergy so that you accomplish what you're trying to accomplish. And these kinds of diagrams are very helpful for people who are trying to learn this, or even a more seasoned person, to think about all the different variations to accomplish the goal that you're trying to accomplish for your particular patient, the support that they might need. Here's venous drainage, and then arteriovenous. So they're taking 2 femoral veins, returning to the femoral artery, and returning to the right atrium. So they're trying to get huge drainage, and they're trying to return to the central circulation for systemic blood pressure, for circulatory support, but then they're also trying to supplement the lungs coming into the right atrium. Here's VVAV, same thing with different vessels. And then you've got this one, VVVA, and they're draining from 3 places and going back to the femoral artery. I've never done that. I've done several of these. I haven't done that. Has anybody on this panel done VVVA?
No.
Okay, so nobody's done it. It's there though, and you know what? You can do it. That's what's important to know. So this is a real interesting slide. This is actually VA ECMO, but there's a problem. There's something. This is how they have it labeled as VA ECMO. Does anybody see what is odd about it? Let me go over this real quick. So here's the femoral vein access. You see it coming down right here. Here's the other femoral vein access, and you see it coming right here, and it's mixing in right there to the venous line. That's the blue line. You can see it right there. And then here's your return coming to the femoral artery on this side and going to the femoral artery on that side. But what do you notice that's odd? Anybody on the panel? If they couched it as VA. Okay, I'll bring your attention to it. Look at the color of the venous line, and then look at the color of the venous line. This is in the femoral vein, and this is in the femoral vein. This is dark. That's bright arterial blood. Why?
Well, you have shunting going on. You have mixing going on.
Good thought. Nope, not the answer. So the reason for it is they're using, oh, didn't mean to do that. They're using this line through the femoral vein, transeptal to the left atrium. So they labeled it as VA VA, but it really isn't VA VA. And I had to look at that picture for the longest time, and I had to dig in. You have to read the small print. It's labeled as VA VA, but then they go on to explain where all these cannulas are. So the cannula is in the femoral vein, but the tip of the cannula has gone transeptal, it's in the left atrium. So in this configuration, though you have two arterial returns going into each femoral artery, to your point, John, with full flow, you have far less of a concern of LV distension and LV wall tension increase because you're able to vent the left side of the heart with this configuration. Common complications, this is the most insidious of all. There's no question about it. There is nothing worse than seeing a patient on ECMO with peripheral Fem Fem cannulation and poor lungs, but a healthy as could be heart with inadequate flow. And you go, we got a problem here. Got a problem here. No, we drew a gas and it looks great. Where did you draw the gas from? Well, the other femoral artery. Okay, do we have a radial arterial line? No, we don't have one in. But can we please get a radial arterial gas? And the saturation is 50. That's very, 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 very bad. So, another common problem Dr. Balan discussed, cold foot, ischemic foot. It looks bad, and it's only going to get worse. This is that cannula that he talked about, where you come off the side port of the arterial return line and put the catheter into the SFA. This is a little bit better example of it that you can see here. They did a cut down, obviously, for insertion on this. This is what it looks like diagrammatically, and on the right-hand side, you can see how they did that with the cut down. One of the things I thought was odd about this is, generally speaking, if you look at this, you can see they made a counterpunch to come in. Here they didn't, so I am assuming they're planning on reopening this area up. You certainly wouldn't be able to take these cannulas out percutaneously with all of this in there and just rip that through the skin. At least I wouldn't. So you're probably going to open that patient back up. But you can see, he said that here's the arterial return cannula. You can see that it's pointed towards the toes. So the toes are down here, and the head is up there. And so you have your arterial cannula, and then reversing coming down this way. And that helps to avoid that ischemic foot and losing toes and so forth. Let's see. There we go. This is another chart showing the increase in LV wall stress associated with VA ECMO with peripheral cannulation. Again, putting it in, getting the patient stabilized and protecting the rest of their body initially makes a lot of sense, but you have to evaluate the patient after you put them on VA ECMO, whether it be whatever kind of cannulation, but especially with peripheral cannulation, as to what's going on with the heart. But you can see here, using the Impella or using the tandem, you can see that LV wall stress is much, 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 much lower. And John, to your point, you notice here, the more you flow, the worse it gets. So actually, it's counterintuitive what they were telling you, because I think your point is right. Your point that the more you flow, the worse it's going to get, even in the absence of AI. Though I think everybody has, especially if their heart's not moving very well, that valve might pop open a little bit, and the blood rush gets in there, and it just keeps collecting and keeps collecting and keeps collecting. And that's, of course, a big problem, too. Huge problem that I don't even have on this slide, in deference to time, is LV thrombosis.
Correct.
You can get enough blood in there, and if you're using poor anticoagulation, or they want to turn off the anticoagulation, the ventricle clots. You were going to say?
I was just, even if you are well anticoagulated, if you're in a closed space with blood that's just sitting in the LV, it will clot.
Yes, yes, absolutely. Over time, it eventually, absolutely, eventually, it certainly is going to.
And Joe, one thing that I notice people seem to forget sometimes is even if you had a perfectly sealed aortic valve, which very few of us actually have, all of us have a trace amount of AI as a general rule, and even if you did though, you still have bronchial circulation.
Of course,
filling up
with
the
direct
left atrium,
cavitary
left ventricle.
return.
So if you have a motionless left ventricle and somebody says, well, we don't have any AI, you still have distension because it's going to constantly come in from the pulmonary, so from
That's
the
right.
bronchial circulation.
I totally agree. And let's see. There you go. And this is a really nice looking echo. And what you can see here, and as I said, I do not think that Impella is a bad device. I think it's a good device actually. But you can see here the left ventricle is on the right side, grossly distended. You can see the interventricular septum is bulging into the right ventricle. And this is a very distended left ventricle. And it's going to have a very hard time recovering looking like this. It's not going to, the coronaries are not going to perfuse well at the microcirculatory level, and it creates a lot of problems. In fact, distension itself increases O2 consumption.
Myocardial oxygen consumption.
So that is, so distension itself is bad. But you can see here with the Impella in acting as an LV vent, your septum has centered itself. The RV and the LV both look more normal. And this is a much healthier looking situation for opportunity for recovery. This is just a quick little notation about aortic LV thrombus and also LV wall stress. You can read it later at your leisure. And this is, of course, talking about the Impella being inserted and used as an LV vent for patients with LV dysfunction on peripheral cannulation VA ECMO. It tends to be less of a problem with central cannulation, but it doesn't completely eliminate it. Central cannulation is helpful because you've usually got a much bigger tube in the right atrium and you get better drainage. But and you have less opportunity for Harlequin syndrome, except maybe the coronaries, if the LV is if the heart's functioning at all, depending on how low or how high the coronary ostia are. But you can still have the problem even with central cannulation. I'm a big proponent of venting the left side somehow, but Impella is not the only way to do it. I'll show you a little more. But don't be this guy. Never. How are we doing on time? Good? Never use VA ECMO with peripheral cannulation, meaning Fem Fem, for pure pulmonary failure when there is no LV dysfunction. I've seen people do it. And I've seen them do it with grossly undersized cannula on top of it. And it was very, again, don't be this guy, please. So let's look at this is a tandem heart, left heart catheter. It goes in through the cava transeptally and then resides in the left atrium and is an excellent tool for venting the left side, relatively easy to put in, and a lot less problematic with positioning than what you have with the Impella. Once you get this thing in position, it tends to not migrate because the pressure differentials are so different and the action of it is so different. You know, as opposed to an axial pump that's spinning at 50,000 RPMs, that tends to want to draw itself in. And the slack on the line and the artery and all of those other reasons. So again, I'm not anti-Impella. I just think that there's other ways to do this. For the right side of the heart, this is the Tandem Heart Protect Duo. Of course, this is owned by LivaNova now, but that's a corporate thing. Nevertheless, it can be used for two things. It can be used for right ventricular support, because you go in usually through the right IJ and then make the turn and go into the pulmonary artery because you're drawing blood from the right atrium and returning it to the main body of the pulmonary artery. So you have two things get accomplished here. One is you're supporting the right ventricle. The second is this is an excellent way to do VV ECMO with a single cannula that has almost no recirculation. The only problem with it is that it's not as easy to put in, let's say, as an Avalon or a Crescent, and I'll show you those going forward here. It has an advantage, but for example, an Avalon catheter is plus or minus 2,500. This catheter is 18,000. So hospitals are a bit reluctant to want to use that. They will use it in Canada. They use it in Canada. They'll sell it separate in Canada for 11,000. But this is what it looks like. And the nice thing about it is that even with some RV dysfunction, you can exercise your patient. Because you're in the neck, all the cases we've talked about here today have nothing to do with taking a patient who has as a CO2 retainer that's waiting for their lung transplant that you're going to want to exercise to keep them conditioned for surgery. We're talking about acute illness, totally different phenomenon. Nevertheless, I prefer the neck over the groin for infection. I prefer it because it's much easier. You can sit the patient up, which is hugely helpful in patients with ARDS. You don't want them laying flat. It's the worst thing you can do. It gives you the opportunity, for example, to use the rotaprone, which we can do. We were trying to get rotaprone to give a talk today, but they would never call me back. But we do ECMO, you do a lot of it, ECMO with rotaprone concurrently. And that seems to have very good, I think the results on that are really quite good. At least my anecdotal experience with it, what I see seems to be quite good. I don't know what the data shows. Here is an example, a chest x-ray on the left with a drawing on the right of having both a Protect Duo and an Impella both in this patient for right ventricular, basically biventricular support, the right side and the left side, as well as potential for oxygenation if you needed it. So you can read these later. Indications for veno-venous ECMO well published. Here is, you can just take a look at this. You can look at it at your leisure. You can download it later. But this is how you calculate a Murray lung score if you wanted to. Another thing that is very important in determining if your patient is appropriate for or if it is indicated to use VV ECMO is your PaO2 FiO2 ratio. It's a very simple calculation, but here's a diagram that you can download and print and just have with you. It makes it very easy. This is the worst way, in my opinion, of providing veno-venous ECMO, which is the very easy to do typical femoral approach for your access with usually, either Medtronic or Edwards along, femoral cannula, and then return with a shorter femoral cannula in the right atrium. This really results in a tremendous amount of recirculation, and I don't have very positive experience with this technique. It's easy, but I think you have two problems, a lot of recirculation, and again, here you've gone into the neck and you're going into the femoral vein. I think for a crisis and an emergency, fine, but I don't think you should leave patients like this. John, you have any experience with this? You do a lot
Well,
of
the amount of work that takes to put into the IJ, you might have just ahead put in an Avalon,
I think so too.
Why would you go through all that double cannulation when you could have done a single cannulation?
They do. It's certainly an issue, but I don't like it. Here are various different ways to do the same thing. On the right side is what we just discussed, but on the left side, what you see is two femoral cannulas, both in the veins, with your access more inferior and your return more superior towards the heart. This is actually pretty good. The only thing it really doesn't capture or help you with is what's coming back from the superior vena cava, and we know that's going to probably be pretty low. So it doesn't help you a lot there, but it is a way to do it to reduce recirculation. You can even use a short femoral return catheter as your access if it's big enough, and then use the typical femoral access catheter as your return all the way up into the atrium. This is an Avalon. It has the advantage of having dual lumen, being a single cannula to both provide access and return, access from the superior vena cava, the inferior vena cava, and then the return is here, supposedly positioned in a way that jets towards the tricuspid valve. I think that's a very hard thing to really do. What most people tell me they do, whether it's the Avalon or the Crescent, which is the newer version of the Avalon from Medtronic, is they put it in, they get the patient on ECMO, and then they manipulate the catheter slowly until they see no further improvement, but rather a decrease in oxygenation, and then come back and try to find the best place for it. It takes a little bit of time to do it, but it's worth it in the long run. I don't care, you use a bicaval view with the echo and all that kind of stuff, you have no idea whether that thing is jetting towards the tricuspid valve or not. It's just a guess. The best way to do it is to actually manipulate the catheter while you're watching the saturation. There's again the tandem heart duo. That's what an Avalon looks like on X-ray. And here is an ECMO circuit. So I wanted to wrap it up with this. And you have phone lines open, by the way? I wanted to wrap this up with basically a circuit. And I added this one for Kimberlee's benefit, because here you have, or Julie, whichever you are today, because here you have the CRRT circuit. And basically what I'm trying to show you here, that all of what we've been talking about today with ECMO and CRRT and access and return and everything else is just nothing more than a circuit. And the circuit has pressures. There's negative pressures, there's positive pressures, there's different levels of both negative and positive pressure. And all of these things are just that. And you just have to sit there and draw it out and look at it. And it's very when you walk into a room sometimes, you look at an ECMO patient on ECMO and you see all those lines and you go, holy mackerel, where's all of that going? It really is not that complicated. It's a pretty simple circuit. And what you can do with that circuit and adding things to it, or how you can manipulate that circuit to make what you want with the patient to do, is just a matter of understanding the circuit. And of course, that's what perfusionists do every day, so I'll pat ourselves on the back a little bit. I'll try not to hurt myself, but it's why I feel, and don't mean to belabor the point, but that's why I feel that a blended program of perfusionists and nurses make the best ECMO programs, with physicians obviously who understand it as well and who want people around them that can actually have a discussion with them about what they're doing, because we can all always make each other better. So phone lines are open. I think we have about 10 minutes in case anybody does want to call in out there in web world. Please call us. Let me check the YouTube and see if anybody's chatted any questions. In the meantime, why don't you guys talk amongst yourselves, and I'll do that.
I think the most important thing you mentioned, Joe, is it takes a village, it takes a team. And really everyone's expertise is important and is valuable.
I think as we gain higher technologies, it's become more cohesive of a team effort also. I think that wherever I've been, nurses are more engaged with perfusionists, and ECMO specialists are more engaged with nurses. You know, I really see that a lot. And with the physicians and with the CCM, it's everyone's participating during rounds, which many years ago we didn't really have a reason for that, but now you see the whole team participating in rounds and contributing and answering questions.
Oh, I think that makes a huge difference. I think you're absolutely right. I think, historically, perfusion has been sort of, I've always been like that, but, I grew up in a time, where you did your case, they left the room, you set up for your next case, and that came in and you did that case. You barely ever had time to know anything about the patient. And that's just the way it was. And as time has gone on, it wasn't until I started going to the ICU essentially just out of my own curiosity, because we lived in this little silo of the operating room, and just that's all that we thought it all was. And it opened up a whole world, and I was like, holy mackerel, there's a lot going on over here. And that's, but I don't know that we do a good job of teaching that in the programs. I'm not sure.
Well, it seems to be a little bit of a lost art. I grew up in a similar era as you, and when I was at my first job for 12 years, I was the only perfusionist. That was just me for that many years.
Cool.
So it compelled me to walk over and see how these patients are doing, because whatever it was going to be on me, a large part of it, right?
Mm-hmm.
And so the easy people, perfusionists ask me, I don't have time, I'm so busy to go follow the patient. It takes so. No, let me tell you the trick. When you're done with your case, 2, 3, 4 o'clock in the afternoon, and you're on your way out of there, walk into the ICU and just go up to the nurse for your patient the previous day, which has now been in the ICU for 24 hours. Just walk up to the nurse, stick your head and say, how's the patient doing? You want to ask 4 quick questions. This takes a minute. You want to ask, how are they doing on the vent? Did they wake up? How's their coagulation status? And what's the urine output? Just ask those 4 questions. They'll rattle that off to you in 60 seconds. Mm-hmm. If you can ask those 4 questions, this won't take any time at all, and do that every day, you will learn to be a better perfusionist, because you will see, wow, this patient really gained a lot of weight. This patient's 12 pounds overweight. Maybe I should have taken off more fluid. This patient, urine output was great, because I did such and such, or this urine output is bad, or the patient's coagulopathic. You'll know after a while that maybe you could have done something different, and it takes 1 minute of your time at the end of the day, and it's the perfect time because the patient's been in the ICU for 24 hours.
Mm-hmm, mm-hmm.
Did they wake up?
Right. We don't see the patients pre-op. Mm-hmm. We really don't ever see the patients post-op. You interact with the families, mm-hmm. and you actually do interact with the patients. Mm-hmm. When they're leaving your ICU or whatever it may be, you're with them for a long time. You see them in follow-up and all of that. We don't. We don't spend any time. We know very little about who they really are. Mm-hmm. And everybody's got a story, right? It's kind of interesting, that ECMO patients are different though. This is just standard, the regular cases we do in the operating room. ECMO patients, because we're there all the time. Now we're interacting with the family. Mm-hmm. And sometimes that's a double, it's good that we do it, but there are times when I'm not so sure I'm glad I'm having to do this, so it's kind of you're very good at it. You interact. I mean, I've watched Kimberlee work, and I've worked with her for 10 years, and impressive at how your entire unit interacts with these families during the most difficult, one of the most difficult times certainly of their lives. And they're on ECMO, and there's all these machines and CRRT, and sometimes a balloon pump too, and it's a lot of work.
We take a lot of time to communicate with our family so that when it does come to a point where we need to talk about withdrawal, they really understand what's been going on the whole time. They've been active, they've been in the room. We have them step out twice a day, 6 to 8 in the morning, 6 to 8 at night. The rest of the time, we welcome them to be in the room, ask us questions, ask perfusion questions, and then when we have to have those difficult conversations of there's nowhere to go from here, they really understand that you really have given their loved one every shot that they could possibly have. And it makes it a lot easier to come off at that point.
All along, you have to be open, honest, and upfront with the patient and the family so that everyone understands, just as you're saying. When that time comes where you have to make that difficult decision, if they're prepared, it's much easier. It should not come to anyone as a surprise.
Correct.
So before we end this, let's end it on a happy note, because we all do it for when we have those saves.
Oh, yeah.
And those saves matter. The sad part about it is we never learn as much from the saves as we do from the failures. We always learn better from our failures. But we do have a lot of saves. And glad we do this when that does happen, because it really does matter. Are there any questions from the studio audience? Mike, you have a question?
No, I thought the presentation was great. It was amazing.
Is that Patrick?
Yeah,
Hey, Patrick. I didn't have my glasses on, so I couldn't see you. You have any questions?
I haven't seen enough of the presentation to know what the questions would be. I just walked in.
Oh, do you want to know when the crawfish will be ready?
Yes.
I'm cooking crawfish after this, okay?
I do have a question.
Yes.
In the United States, what percentage of specialists that monitor ECMO are not perfusionists?
Okay, good question. So Mike's question in the audience was, what percentage of professionals in the United States that monitor ECMO are not perfusionists? I think I know the answer to that, but John, I'm gonna kick this over to you.
Well, I don't know the actual data, but from my experience, the only time you're seeing ECMO specialists who are really off on their own is at large centers that are very busy. The others that only do, even if it's 1 or 2 a month, which by a small center that would be a lot, they just can't get the experience and the hours and the expertise to be able to be, and even if in the case of ECMO specialists, perfusionists is either in the unit or in-house, always, yeah. That I've seen.
So blended programs.
Yeah.
So Mike, I would say I recently went to an ECMO training class, and as you know, we are as an organization opening an ECMO, an ECMO training center, an ECMO specialist training center here. I do know that there are exceptional respiratory therapists, and I really respect that profession. I think they work very, very hard. Curtis is one who I think is an exception. I tend to believe, and if you look at ELSO is very pro respiratory therapy. Okay, so they're very pro respiratory therapists serving as ECMO specialists, and I don't disagree with it. But I feel that nurses better understand, especially a critical care nurse, the milieu, if you will. They understand pressors, multiple pressors. They understand inotropes. They understand fluid balance. They understand coagulopathy. They understand nutrition. They understand, you just keep going down the list. It's a very long list, and it's what they do every day. So I believe that a blended program with perfusion overseeing and participating, but nurses essentially doing the heavy lifting, critical care nurses that are trained as ECMO specialists, will, in my view, provide the highest quality and most diversely educated and experienced person at the bedside to manage the ECMO. That is my personal view.
I've come up with another question.
I guess all of you, none of y'all want to be on the hit list of the respiratory therapists. Thanks. Thanks for saying nothing, just leaving me out there. All right. I thought I'd get a little bit of yeah, I see your point. Okay.
So I glanced at the syllabus for this, and I know that you probably already talked about reimbursement changes, which we're now, I guess, 6 months into that at least. Have you seen any change in the volume of ECMOs?
Since they can't hear you, you have to tell me the question again, but you have to do it so that I can repeat it, because I have the microphone. Unless you just put the microphone here.
No, that's fine. I'm asking the panel if they've seen any change in the number of ECMOs that we're doing because of the reimbursement changes.
Okay, so the question from the audience is, and they just got him a microphone, but nevertheless, I'll just ask it if it's okay. The question from the Patrick in the audience is, based upon the draconian reimbursement reduction cuts that occurred recently with CMS for ECMO, has anyone seen, or are you all anticipating a significant reduction in ECMO therapy being utilized because of that cost reduction? Did I ask the question properly?
Yes.
I haven't seen it yet. We're expecting it, but I don't believe we've seen it yet.
We haven't seen it yet.
I would say that I think I've seen a little less utilization. Hopefully it is not at the expense of patients, as in when a patient needs ECMO, I think they're getting it. Hopefully, as you pointed out, we're seeing fewer of those unnecessary utilizations.
That's a huge problem. Here's a question though. That's a very good question from Patrick in the audience. Patrick, feel free to answer this too. Do you think it will cause a hospital to think twice and possibly not initiate an ECMO program at their hospital because of these cuts?
Of course, administrators are concerned about reimbursement, so sure.
More than likely. You think more than likely? What do you think?
I think perhaps that, as well as a program that may have just gotten out of the gate and is doing very few, may be in a little bit of a pickle as to where to go from here.
So may abandon their program.
Well, they're probably considering what their options are going to be, I would think, because it was unexpected that deep of a cut, I think. You know.
We've had to be very careful in our patient selection to sell it to administration and not choosing either putting them on late or futile cases when starting it, to really say it's worth it in the long run to be competitive in the area that we're in. We really need to offer this as a service.
Did you want to add anything to that, Patrick? Oh, good, you got a microphone.
I think I'm live on the mic, is that right? Okay, yeah, and you may have already discussed this before I got here, but I'm curious if the reimbursement changes had anything to do, or if it affected the pediatric ECMO, which I think is probably the biggest area that we're using this.
I don't know the answer to that. We need Curtis here.
I'm not apprised of what's going on the pediatric side.
We don't know.
Okay.
Sorry. It's a good question, though. Okay, well, I think I could ask 100 more questions, but I think thank you all for being here on Saturday. We appreciate it so very much. Reminder, you need to go to Perfusion Education library.perfusioneducation.com. Make sure you it'll say quiz, but it's an evaluation because you were here for a live event. Do the evaluation, and as soon as you complete the evaluation, boom, the certificate automatically opens up. It's put inside your folder if you're a registered participant, obviously, and those CEUs will be awarded to you for today's program, yesterday and today. So again, thank you all very much. And if you were here, I'd invite you to the crawfish boil, but you're not, so we'll take some pictures of it and show you next time. We'll see you next month. Thank you all very much.